Thank you for the introduction. I'm a sort of a newcomer to this community. Nicola reached out to Brian and wanted Brian to come, and you got me instead. So I apologize for that, but hopefully I will be able to tell you some interesting things about what we're thinking about the next steps for this disease. And I thought I would tackle this concept of persistence, and this is really one that the prior speakers have touched on, but I think is really at the core of what's interesting about this biology and ultimately one of the key questions for our patients. Is this thing supposed to advance somehow? There we go. So there are my disclosures. And so I think we've touched upon this, but this data was really compelling to us when we saw it, and this is actually going to be presented by Tomas Ravejevic in a poster on Sunday, looking at the US SEER data and the all-cause risk of mortality in patients with CML as compared to other malignancies. And it's really remarkable that the all-cause mortality in our chronic phase CML patients in the US is twofold that of the general population, similar to CLL, worse than non-Hodgkin's lymphoma, and significantly worse than APL or hairy cell leukemia, which do much better. So I think there are a number of reasons why our patients might be dying at an excess rate. I think there are certainly socioeconomic contributors that play into this, but there's also compelling data when you look at the toxicity of some of our treatments. And this very nice meta-analysis done by Leif Senke at the Karolinska shows some of the things that are cropping up, particularly in our patients on second-generation TKIs. And what really fell out of this, there's a bunch of data in this paper, is that patients on dasatinib and bosutinib have really high rates of infection. This was striking to me. I don't notice this clinically, but the data is very clear. Whereas patients on Tasigna and ponatinib have the expected cardiovascular mortality, and I think this is really important to think about as we, continuously switching our patients more and more to more potent inhibitors, trying to chase TFR. What are the toxicities that we're bringing upon them with this? I asked one of my patients to write a little statement for me to talk about what her life is like on TKI. Many patients do well, but some of our patients really continue to suffer. And so I'll read this to you. So I was diagnosed with chronic stage CML in February of 2005. I was told by a PA that before too long my CML would become a background noise in my life. Almost 18 years later, I am still waiting. Unless I'm off therapy, I live with drug-induced depression, cognitive impairment, fatigue, shortness of breath, chronic pain, changes in vision, rash, cramps, so on and so on. My life is a series of energy management decisions of what I can and cannot do on any given day because of the impact of TKIs on my life. And this is really a powerful statement. And for this particular patient, we stop and start her treatment all the time, depending on what she needs to do. Her husband has multiple myeloma and needed a CAR-T therapy, and so we had to stop her therapy so she could care for him. There's real burden here. And so, as Mike pointed out, there's this perception that chronic phase CML is frequently dismissed as a problem that is solved, but we respectfully disagree. So my real question is, why can we not get more patients off of therapy? I think that ultimately we're going to deal with the economic burden, the toxicity burden, and all of the other burdens that our patients experience by getting them off of therapy quicker. And so I thought I would go through a couple of different patterns from patients in my clinic of what I see as persistence. And I'm going to pose the question about whether there might be shared biology here. So this was a woman who came to me right at the start of my faculty appointment in 2021. Who had long history of CML, actually had a year of dasatinib treatment prior to when she arrived in my clinic. She was on Bosiliff, she was pancytopenic, needing growth factor support. Her PCR was pegged at 100%. She was in chronic phase. We switched her to ponatinib with the hope that maybe more potent TKI might, overcome some adverse disease biology. Tried to work her up for transplant, but she progressed to accelerated phase before we could do that. Being a Seattle acolyte in training, I gave her GCLAM induction because she was fit and I wanted to hit this as hard as I could. We got her into MMR with GCLAM and she went on to transplant. And what was really remarkable here is that the TKI was controlling the proliferative component of the disease, but her PCR wasn't dropping. So that's a form of persistence. Another form of persistence that we all have seen is the patients that fail to achieve MMR. So here's an example of a patient who, by all rights, was a low so-called risk disease, should have done well, didn't meet milestones on imatinib, got put on nilotinib, got close to MMR but had a treatment interruption, disease rapidly came back, and it's been sort of hovering above MMR around a PCR of 1 on dasatinib. This is another form of persistence. Here's another one which we've published before. This is a patient that had been in a deep molecular response for a long period of time after treatment with imatinib. Imatinib was held early in 2010, was still undetectable until 2012, and then came back up. And fortunately, this was a patient of Brian's. He was patient, followed the PCR, and lo and behold, it just bounced around somewhere between undetectable and 0.01, but still in MMR. And this patient is still bouncing around there. This is another form of persistence. And I think an interesting case that we often discuss when we think about immune control is this a patient with immune control where there's a clone that's being restrained somehow. And finally, another pattern of persistence is the individual who fails multiple TFR attempts, right? So this was a young woman, achieved a deep response on Tasigna, relapsed immediately after holding, restarted on dasatinib, immediately undetectable again, and then relapsed immediately after stopping dasatinib. There's some cell here that we can't get rid of, right? And there is this notion that time on therapy does improve your chances, but this pattern is very compelling to me. This was not subtle. And one wonders if we're ever going to eliminate all disease on this woman. So my question, and really a question to the group, and the questions that I'm thinking about as I plan projects in my lab is, why do these cells persist? And is there a pattern is there shared biology across all of these different types of persistence? Is there a relative resistance to our TKIs that can be partially overcome by more potent agents, but really varies between our patients? So what might be the causes of this? So certainly there's been an extensive amount of work done on signaling pathways downstream of BCR-ABL, and there's been discussion about whether factors either from the non-kinase activity of BCR-ABL or other growth factors, other signaling pathways, microenvironmental factors might reactivate some of these key cell survival pathways downstream of BCR-ABL. And Mike nicely listed all of the trials or all of the preclinical data that's gone into forming some of these hypotheses. And this is one area that I still think that we don't completely understand what is happening truly in our patients that are persistent, but at very low levels. And this is the challenge, right? Because up until now, our ability to study these mechanisms has really been limited to patients, early in the course of their disease or cell culture models, which do not recapitulate what is happening in patients with more advanced disease and who are persistent. Others have gone on to show that cooperating mutations lead to poor outcomes, particularly sort of the ubiquitous epigenetic regulators and transcription factors, that if these are present, patients are much less likely to achieve MMR. Still, we do see patients with, ASXL1 mutations who manage to clear these clones with effective ABL inhibition. So there's some other piece to this that does not necessarily correlate purely with those mutations. Something that I was thinking about when I was putting these slides together is how little we really know about the rest of the Philadelphia chromosome. So for those of you that aren't familiar with these sorts of plots, these are chromatin contact maps where the red dots show areas that are in proximity when you ligate the DNA. So up at the apices of those triangles are distant areas that come into physical contact. And we know about this on normal chromosome 9 and normal chromosome 22, but we have no idea how these are altered when the Philadelphia chromosome forms and how other genes might be regulated. And this is really relevant because there's increasing evidence that regulatory elements from one gene can be brought in proximity to key oncogenes. So this is an example from Roux de Waal's group, where they found that in inversion 3 AML, there's an enhancer that regulates GATA2 expression that is inverted into the EVI1 locus and then regulates the expression of that crucial oncogene. And as far as I can tell, we haven't looked at this in CML. And this could be, this kind of enhancer hijacking could really drive oncogene expression in CML. So that's something we should think about. Mike mentioned microenvironmental factors, and I think on his slide, there's been thoughts that certain cytokines in the microenvironment, CXCL12, CCL3, TPO, might be involved in promoting the survival of leukemia stem cells and contributing to persistence. Again, this comes from mouse models and really hasn't been evaluated in patients that are in deep responses. There's this question of immune control, and I'm hoping that when we have the panel discussion, we can have some debate about this. This is a debate that Brian and I have in clinic almost every week. How strongly do we really believe this? There's certainly data from Euroski showing the NK cell counts correlate with the risk of relapse. There's the interferon data showing that patients that receive prior interferon are much more likely, or not much more, somewhat more likely to be able to successfully achieve a TFR. I threw this slide in because when I was pulling that slide, this one caught my eye. No one's ever talked about this that I know of. This, the risk, the difference in TFR success in men and women. We don't talk about this. It's probably important. I'm curious to hear what others think about it. Please, yeah, I look forward to it. So coming back around to this immune control argument, this is kind of the way that the debate goes, right? We have these high response rates to DLI after hematopoietic stem cell transplantation, correlation of NK counts, interferon data, and then we have this clinical observation of these patients who have long-term, durable, deep control without TKI, and is there an immune control component? The flip side is it's interesting to speculate why patients are able to be successful on a second TFR attempt. Does the immune system change? It's a little bit more challenging one for me to completely understand. And then data that was interesting to ponder was data from the last trial where they used digital droplet PCR monitoring. And this technique can get you down to MR5 or MR5.5. And when patients are undetectable by digital droplet PCR, they have a very high rate of being able to maintain a treatment-free remission, which again suggests that in some of our patients, they are truly getting close to or absolute clearance of their CML. And maybe the immune system plays a role in getting them there, but it may not be contributing to the durability of that response. So things that I'm thinking about as I begin to put together projects in my lab and think about some of these things that Mike was talking about how can we really think more deeply about these patients using the state-of-the-art techniques. We really need to be looking at the biology of the cells in our patients, is my view. And I think that we now have the techniques to deeply characterize rare cell populations using single cell architecture and biology to guide our thinking about the biology. And so we're working to develop tools that are going to enable us to jointly profile single cell chromatin states, single cell transcription, as well as identify BCR-ABL positivity so that we can link that information and find those residual CML cells in the bone marrow of our patients. Similarly, I think that we have a plethora of really sophisticated modern cancer immunology methods that are available to us that we can apply to try and understand this question of immune control and whether this is really what's going on in our patients, and if so, how can we intervene in it? And at least my view is that the success of imatinib has really focused us on BCR-ABL, and that we ought to now be revisiting what are the other things that the Philadelphia chromosome does, and could some of the variability that we see in those breakpoints actually be contributing to the variability in the biology that we see in our patients. So with that, I'm happy to take questions and hear people's thoughts who've been thinking about this for longer than I.
Okay, open for questions. I might start. The data you showed with the surprisingly poor survival in CML patients compared to everything else.
I know, it's shocking, right?
I don't understand that. And how do you reconcile that with the Swedish data, which looks like, I mean, I never kind of believed that it was almost as good as survival with CML as with normal, but this is showing worse than some other pretty nasty diseases.
Right.
So
that's what we tell our patients, right?
What are they dying of? Is it CML or is it non-CML causes?
Yeah, so, you know, that's, I haven't seen the data. You'll have to go to Tomas's poster. Yeah. But I think it's fascinating. And I too, they have data that AML has a relative risk of about 2, similar to CML, which seems really weird to me. So I'm going to go by and ask them about that too.
Yeah, I don't know. It's kind of hard to reconcile.
It's hard to reconcile, I agree.
Other questions?
Thank you very much for this very interesting presentation. I would like that, however, probably we have given little attention to the data of the DESTINY trial, in which rather than to discontinue abruptly the TKI, just we are discontinuing them little by little with a half dosage for 1 year or so. And the results of this trial are showing, the results which are so far published, I think, they are showing that the percentage of those patients who are remaining, we'll say TFR, is quite higher with respect to what we have seen in other trials. Yeah. So I think that this can be replicated, of course, must be replicated, but I think that probably there is also some biological explanations why this is occurring. And if this is true, probably it involves also maybe the expression of some antigens which can promote, I would say, the immune response and so on. It can be several reasons. So I think that this should become probably something that in clinical practice may help the discontinuation without requiring all this intense monitoring that we have to do after stopping a therapy and so on, and maybe making this TFR approach more accessible also in many other countries. What do you think about it?
Yeah, I mean, I think it's you make a really good point. You know, something that we've been scratching our head about is that it seems like if there is an immune response, it has to be directed at a BCR-ABL peptide. There's really not a lot of other antigens that it could be, and there's really limited, amino acid space there. For that immune response to be driven off of. So something we've been thinking about doing is trying to do like a peptide library screen to see if we can identify reactive T cells from any of our patients that were responding to BCR-ABL peptides. Because if we could identify a few conserved peptides, then we could really start to evaluate those specific T cell clones in our patients. The other way to go about this is to take a little bit of a broader approach and do T cell receptor sequencing, look for clones. The challenge is that we don't really have the computational tools yet to take that TCR sequence and then convert that to peptide specificity. So I think there's still some development to happen there, but I think we're starting to get the pieces that we need to be able to develop those sorts of tests.
Yeah, I mean, it's fascinating data. The DESTINY study, very provocative. I mean, I wonder whether going to a half dose allows some level of cell growth, but you've still got the ongoing, partial TKI inhibition, allowing the immune system enough time to kind of to respond. That's one possibility, I guess. But do we have any other studies to back up DESTINY? Are there other studies that people are doing at the moment?
Study in Russia, there are studies in which they have tried, but for the moment we are lacking the data.
Running a study?
And there are...
Delphine? Hang on, I'm going to get the microphone because we're recording it.
We just have our real-life nilotinib dose de-escalation study that we presented some time ago at ASH, but there was no big TFR data on that, but we will update.
Okay, so we're waiting to hear.
Similar picture as for
halving the
imatinib.
dose. Okay, Charlie, just a second.
I'll offer a second potentially provocative explanation for those data. I mean, at some level, this is about a therapeutic index. right? And is it possible that really what we're seeing is a competitive relationship between the BCR-ABL positive clone and the residual healthy stem cells, and that you actually may get a better therapeutic index at those lower doses? It's something to think about. We know that TKIs are able to inhibit normal hematopoiesis. Something we haven't really explored is that clonal competition.
Yeah. That's a really good point. And I must point out that Sue Branford has a poster that Naren is going to be presenting on Monday, looking at the, tomorrow, looking at the impact of having clonal hematopoiesis and how that actually has an impact on treatment-free remission. It doesn't seem to improve the rate of TFR, but it does dramatically change the timing of relapse, and perhaps because of a competition between a more vibrant clone and the leukemia. So, yeah, have a look at that. It's quite interesting data, and I'm sure other people have data they would put with that as well, because I think that's would sort of support that idea of it's a competition that's dynamic, and maybe by halving the dose you're favouring that competition. Any other questions? Yes, Charlie.
Yeah, and the other possibility in the Destiny trial is that having the dose had nothing to do with it, and that there are a group of people who are between 10 to the minus 3 and 10 to the minus 4 who will achieve TFR if you stop at a lower rate, but at a real rate. So let's say that rate's 20%. That's a lot of patients. And I wonder that that's not a clinical trial that ought to be done. We assume, what you can't assume, because that it's the drop in the dose, but that may not be the case. Because our study, the last study, was done at 10 to the minus 4, others were done at 10 to the minus 4. That's a hell of a lot of cancer that's detectable, right? And yet that threshold was successful, and I think it's quite conceivable that there are people who are between 3 and 4 who, for reasons we don't understand, can successfully stop.
I'm going to point back to this patient here, right? There could be patients that are hanging out there that could stop, right? It's all about where do we feel safe.
Well, I think you're safe, almost 100% safe.
I think
if
so.
People are willing to put up with it. That's the beauty of it. This intervention is almost 100%
Do you stop
safe.
patients who are in major molecular response and not deeper?
I haven't, but I'm suggesting that
I worry about it.
We're ignoring that, and I guess I never will, right? Because I don't do it anymore. I'm suggesting there may be a group of patients, and it's an easy clinical trial, and it's a safe clinical trial.
There were a cohort of patients in the Destiny study that were in that sort of range, and their success rate was very low. Like you said, 20% or something.
Well,
Andreas?
it was 20 to 30%, but I think you're going to say that most of them were closer to 4, right?
Okay, final point for this talk, a final question from Hemant.
So more of a comment, I think, and it's been said like in this discussion, I think the immune system is probably playing a big role. We have a large number of population of patients in India who are on the GPAP program, and they don't have an option of escalating to the second generation TKI because of economic reasons. We can increase the imatinib to 600, 800, sometimes it already 600. And they remain in the BCR-ABL 1 to 10 group for years on end, and nothing happens to them. They do not progress, or very small percentage progresses. So maybe the bar which we are setting of MMR or MR4, maybe it's too low. Maybe you don't need that lower bar.
Well, yeah, maybe, but sorry, it's your question.
No, please.
Well, I mean, we need to see the data because even when we used hydroxyurea, many patients went 5, 10 years, and you might think, in fact, the hydroxyurea was actually improving their outcome. Maybe it was slightly, but I think we need to see the evidence. And but I've heard similar accounts from other groups say that it's still worthwhile continuing the TKI as long as you're getting hematological control. Yeah, Pat.
I always think Hermant is in charge of the rest of the world, so I'll go with him and help him. I mean, ICMLF says you want to cure CML. Do you think we know enough about the biology of all CML patients from everywhere in the world? Or are we trying to cure certain patients? Because I'm worried that the biology is not the same.
Yeah, I mean, it's a really good question, and I think they're studies that we need to do, and that's something that, for some time we've been interested in collaborating with groups in India, groups elsewhere, to look to see whether there are key biological differences. I think that's a really important point, Pat.